So what is normal posture? Normal posture is when weight is taken evenly through both ITs, the pelvis is in a minimal anterior tilt, the head is balanced and aligned above the hips, and the feet are rested in neutral. So that is the normal or correct posture. But I'm sure the people that are watching this here today, if you're sitting on a chair, you are not sitting in this normal 90-90 posture. Because normal posture is also what is most comfortable for the patient, what is most energy efficient, what is task specific because we change our posture depending on the task we're doing, and also what is less damaging in terms of function and pressure. So what prevents us from maintaining this upright posture? And the answer to that is gravity. Gravity is working against us all the time. Now, when we have our normal anti-gravity muscles are working, we are able to hold ourselves upright against gravity. But unfortunately, the clients that we're dealing with, due to neurological impairment, old age, or some sort of medical condition, they no longer have the ability to maintain an upright posture. And therefore, these are some of the postures we will encounter on a day-to-day basis with our patients. So the first and the most common posture that we will see is posterior pelvic tilt. This is also called sacral sitting, and it's common when people sit for long periods of time. But it becomes dangerous when people slide into this posture and are unable to correct that posture. And when they're unable to correct that posture, they're at high risk of developing pressure injuries or pressure ulcers in the sacral, the spine, and the heel areas. In this posture, the PSIS is lower than the ASIS. So what causes someone to slide into this posture? As an OT, when I'm looking at this and doing an assessment, I'll always look at the clinical reasons first. So some of the clinical reasons why people might slide forward in a chair are tight hamstrings, limited hip flexion, abnormal tone in the body, or the trunk muscles are unable to hold the spine upright against gravity. But the technical causes is what we're concerned about when we're looking at seating, and it is the dimensions of the chair. So if you've got a seat depth that's too long, it's going to cause the body to slide into posterior pelvic tilt. If the floor to seat height is too high, if the foot plates on the chair are too low, so therefore there's inadequate foot loading, if the back of the chair is too straight, or the armrests are too low, and if the seat depth is too short, therefore inadequate femoral loading. So all these technical issues may cause the client to slide into a posterior pelvic tilt, and if they don't have the ability to correct themselves, we have to think about the long-term effect of sitting like this. So think about the effect it's having on their swallowing, on the respiration, on their speech and communication, on digestion, the pain that it's causing, and also the damage to the skin. So then look at anterior pelvic tilt. Anterior pelvic tilt is less common, especially in the older generation. It's the posture that you have when you're sitting at a desk, where the pelvis is sitting forward in the chair. In the clients, it can be caused by flexion contractures at the hip. The ITs are pushed backwards, and the area that's prone to skin breakdown is the pubic region. And in this posture, the PSIS is higher than the ASIS. So what causes an anterior tilt? Looking clinically at the patient, if they've got weakened abdominal muscles, if there's obesity, increased lordosis, or tight hip flexors. But I'm concerned about how the chair is producing this problem. So if there's an anterior slope on the seat, if the back of the chair is too vertical, or there's an excessive lumbar curve that's pushing the pelvis forward and into this anterior tilt. And what we must consider is, if people sit like this for long periods of time, the impact that it's having on their bladder, their functional ability, it can cause spinal muscle fatigue, and also damage to the skin in the central pubic region. Now, thinking of the bladder, when the pelvis is tilted forward, it impedes the flow of urine out of the bladder. And if someone is catheterized, it may cause a backflow of urine. Therefore, recurrent urinary tract infections may be a symptom of this. So the next posture I'm looking at here is pelvic obliquity. It's common when people sit for long periods of time, and it's caused either by instability of the person or instability of the chair. and the weight is taken through one IT, so the person falls to one side, and therefore there's a greater risk of pressure ulcers on the side that's taking the weight. It's associated with shear and friction and scoliosis, and when we talk about it as therapists, we always name it according to the lower side. So if someone's weight is going through the left-hand side of the body, we say that's a left obliquity. So what are the causes? In the clinical causes, it could be scoliosis, it could be hip dislocation and subluxation, there could be asymmetry in the body, asymmetry in muscle strength, asymmetry in bone structures, asymmetry in hip flexion, or asymmetry in muscle tone. But how is the chair also contributing to this posture? So if there's no solid base on the chair, so there's a very saggy cushion. If the chair is too wide, the client tends to lean to one side to get support. If the arm supports are too low or too high, or the seat does not support the femurs and feet, therefore we haven't maximised the imprint of sitting. So if someone sits in a pelvic obliquity for a long period of time, the things we have to consider is they're unstable. And we talked earlier about stability being an important function of sitting assessment. So when they're unstable, they tend to fix themselves. And I'm sure you've seen clients sitting with their arms crossed and their legs crossed. And when they fix themselves to stabilise the body, it reduces their functional ability. And it also has an effect on their skin. And in very severe cases where the rib cage is sitting down on the pelvis, it can cause pressure injuries in that region. The next posture we want to look at then is pelvic rotation. And it's when one side of the pelvis is more forward than the other. And usually with pelvic rotation, you find some level of pelvic obliquity at the same time. And we always name it according to the side it's rotating to. So in pelvic obliquity, you always notice a leg length discrepancy. That gives you an indication that the pelvis is rotated. So what are the clinical causes of a pelvic rotation? It may well be that they have a leg length discrepancy or a hip dislocation or subluxation, maybe from an old injury. Asymmetry in hip adduction, asymmetry in hip flexion, asymmetry in hip abduction, or if they're a unilateral foot propeller, which means they're using their one foot to move the chair forward. So all these clinical causes have to be assessed at the time when we're doing a seating assessment. It's really important when you're assessing that you assess both sides of the client. So how does the chair contribute to this posture? If the trunk is not supported, if the back support on the chair does not support the posterior pelvis, and if the chair is too wide. Now I'm going to finish this part of the presentation with 4 more slides, and we're going to look at spinal presentations. And the most important thing from these slides is when we look at lordosis, kyphosis and scoliosis, we need to establish, is the person fixed in this posture or is this posture correctable? Because that's going to make a huge difference to how we set the chair up. So in lordosis, it is associated with anterior tilt, it's an increased tone in hip flexors, and it also can be associated with weakened abdominal muscles. And people with lordosis usually complain of lower back pain. So it's an exaggerated lumbar curve. And when we're doing our sitting assessments, as the therapist, we need to establish, is this a fixed posture or is this a correctable posture? Because something to remember is when something is fixed, we have to accommodate it within the chair. If something is flexible, we try to correct it within the chair. So scoliosis can be associated with pelvic obliquity. It can be C-shaped or S-shaped, and can be associated with osteoporosis. So what we need to establish again, is it fixed? Is it flexible? Is it something that we need to support or accommodate within the chair? And the last slide here on the spinal presentations is kyphosis, and it's a curvature of the upper thoracic spine. It's associated with a posterior pelvic tilt, and it can be associated with osteoporosis as well. When someone has a kyphotic spine, it does reduce physiological functioning, so their ability to breathe, to swallow is impaired. Like if you're sitting there now, if you drop your head forward onto your chin and try, to breathe or to swallow, you know how difficult that is. And that's really important to think about that when we're thinking about our patients. Now, if the kyphosis is fixed, and we need to be able to accommodate that within the chair by loading the spine, by supporting the spine in the chair. And we've designed the Phoenix chair to support the kyphotic spine. Also, if it's flexible, well, then we want to try to correct it. So it's really important that we either support the kyphotic spine or we try to correct it. So this slide that I now have on the screen here, I'm going to talk to you about hamstrings. And it's a very, very important message, and one that is commonly overlooked in seating. So the hamstrings have a profound impact on seating. They're commonly overlooked, and the hamstrings you'll see from the screen, they originate on the posterior inferior surface of the ischial tuberosity, and then they insert in the tib and fib, the head of the tib and fib, which means they go over two joints. They go over the hip joint and the knee joint. So it's crucially important that you test the hamstring range before you elevate the leg rest on a chair. The common problem for people in sitting in chairs is that they elevate the leg rest on the chair, which if they've tight hamstrings, it will pull the pelvis down the seat, and the client will end up sitting on their sacrum over a period of time, which is going to cause skin damage. So one of the commonly overlooked things is the hamstrings. So this is a very important slide, and for everybody who is supplying a chair with an elevating leg rest, make sure that you check the hamstrings before you elevate the leg rest.